Hey guys, Chris here from Lifeline EMS Training. Today we're going to talk about cardiac review. So we're going to do the beats, the squeeze, the stretch, and the snap. So take a quick picture of the heart, right? So we have our vena cava. This is what returns blood back to the heart. Aorta, big vessel that the heart ejects blood out to. If you notice, our coronary arteries branch off our aorta, which we'll get back to here in a little bit. Pulmonary artery here, which comes off our right ventricle. And then we have right atria, left atria, right ventricle, left ventricle. And we also have our coronary venous system. You also see that fat around those areas, and that helps with cushioning to those arteries. So here's our heart. I like to think of things in shapes and colors. So we have our right atria. Right atria takes deoxygenated blood, puts it down to the right ventricle. Right ventricle takes deoxygenated blood, puts it out to the lungs. Left atria, oxygenated blood down to the left ventricle. Left ventricle, oxygenated blood out to the body. You'll notice some structural differences here. So the atria are actually considered auricles, so they're a more thin, flexible, stretchable chamber. And that's important because if they get over-engorged or overstretched or overpressurized, if you will, from too much volume, they'll actually release peptides, which trigger volume retention or volume release with the kidneys. So it's one of the mechanisms your body does for volume regulation based on atrial stretching. So right ventricle is very muscular, but in comparison to left ventricle is less muscular because left ventricle has to eject blood out to the body. Right ventricle just has to eject blood out to the pulmonary arteries. So here's another picture for you. So the vena cava comes back to the right ventricle. Right ventricle goes to, I'm sorry, to the right atria. Right atria goes to the right ventricle. So these are feed points. They're telling you who feeds who. Right atria feeds the right ventricle of deoxygenated blood. Right ventricle feeds the lungs, deoxygenated blood. Left atria feeds the left ventricle. Left ventricle feeds the body with oxygenated blood. So very important. And I'll come back to the vena cava a bunch of times because that's the little fellow that gets no love in the body, but kind of starts the whole process for cardiac output. So, yep, just like we said, there's your flow. Again, how does the vena cava get blood flow? Because the left ventricle ejects through that nice muscular wall the blood out to the aorta. Well, the vena cava gets the blood back to it by you breathing and moving. So when your diaphragm goes down, it makes the container in your thorax bigger, makes a more negative pressure, and draws blood up in through the vena cava to the right atria. One other thing that's cool to know about the heart's ventricles is they don't actually just, you take your hands and you slap them together like you're beating of the heart. That's not how it works. The septum is actually tied to the apices, which is down here. The septum actually pulls up, and then the ventricles actually squeeze. So they ring around that septum. So it pinches up and then squeezes, and that's how it rings the blood up and out into those valves. I always thought that was kind of cool. You can actually see it if you ever go to a cadaver lab and you look at how the cardiac tissue is wrapped around the chambers. So like we'd said earlier, it's just squeezing. So what are our valves? Well, we have the tricuspid valve, which separates the right atria and right ventricle, mitral valve, left atria, and left ventricle. These two valves are different than these two valves. So we have these cuspid valves, which are tied with chordae tendineae here. These tendons are tied to this papillary muscle versus these aortic and pulmonic valves, which are like parachutes. Oops, sorry. And if you look, these valves, when the heart contracts, they actually close. When the heart ventricle goes down and out, they open up. So if you look, these are tied to the action of the ventricle. These, when pressure is pushed against them, it kicks the doors, the little parachutes open, blood flows up. When these ventricles stop their ejection action and go back to filling, boop, that back pressure or that resting pressure of the blood balloons them up and out and closes them. Pulmonic artery, or sorry, the pulmonary artery and the aorta are the same way. So you're looking down here, you're looking down at the ballooning that's going on. It's very important to know that because with coronary perfusion, you have the two coronary os or holes adjacent to the aortic valve. So when does the coronary arteries that feed the heart fill? They feed on diastole. Looking at this pulse ox pleth, the heart, left ventricle ejects blood, systole, aortic valve closes, and this little recoil ripple here is that back resting pressure called diastole. That's when the blood goes down into the coronary arteries and fills them. A good rule of thumb is a diastolic of 60 for good coronary perfusion. Now, of course, that's dependent on rate and demand, but a good rule of thumb is a diastolic of 60. So we have our conduction on the top of the heart. So when that conduction migrates down, we have our main coronary arteries that migrate across the top that you see here, and then they branch down into the tissue, the myocardium. So what's our conduction path? Well, we have our SA node, sinoatrial node up here, which sends its signal down the inner atrial pathways, goes across so that the atria contract at the same time. Those signals are slowed through this resistor-like node, the atrioventricular node, AV node, who gets no love, but its job is literally to delay atrial depolarization and ventricular depolarization so you get asynchronous contractions. By having a good intact conduction system, when the top contracts and fills the ventricles, it actually gives a 20% kick. It's called the atrial kick. It helps the filling of the ventricles by 20%. So if you have a condition like atrial fibrillation where you don't have consistent atrial contraction, you lose 20% efficiency right off the bat. So SA, interatrial AV node down to the Purkinje fibers of the ventricle, and that's how our ventricle fires. What makes electrical conduction of the heart? Potassium inside the cell getting pushed out, sodium getting pushed in. They create an electrical potential, almost like static electricity, if you will. They create a charge because they want to be in the opposite places that they are. One other thing to remember about cardiac tissue is it's rich in mitochondria. Because the heart generates so much electricity to work, it's working so regularly, 60 to 100 times a minute, it has to have a lot of electricity. And mitochondria are the cellular power plant of our body, so they're very rich in mitochondria. One caveat to that is mitochondria, to get their Krebs cycle and cellular energy production, to get that ATP, require a lot of oxygen. So the heart has a lot of oxygen demand. So we're going to go through cardiac output, which is one of my most favorite formulas. Heart rate times stroke volume. This tells us how good the heart is delivering volume out. And this right here is a student's license plate. So credit to Motivated Medic Monica, one of the students I had the very awesome privilege of working with. She actually took the formula because she, I guess, liked it so much, of course, right? And made her license plate on her car, cardiac output, heart rate, stroke volume. I can't imagine that the person at the DMV knew exactly what that was, but it is the best formula. At 2 in the morning or 2 in the afternoon, if you can't figure out why your patient is the way they are, jot down CO equals HRSV and work back. So cardiac output is the volume of blood being ejected out of the left ventricle to the body. It's affected by heart rate, stroke, volume. The three things we're going to take away are heart rate, stroke, and volume. So we're going to break up stroke volume into two different factors. When you're looking at your heart rate, is the heart rate too fast? Is the heart rate too slow? Is it just right? So when you're trying to figure out or use this formula to deduce why the patient is the way they are, look at what the heart rate is doing in relation. If the heart rate's 110 and the blood pressure's still low, they might be compensating. If the heart rate's 200 and the blood pressure's low, it might be a heart rate issue. If the heart rate's 30 and the blood pressures are low, might be a heart rate issue. So heart rate plays into it, right? That's RPMs of the pump times stroke. Stroke is contractility. So how much is the ventricle contracting? How much influence can that chamber get stretched out and slap back in to eject blood? So things that affect contractility, like calcium issues, maybe they're a cardizem overdose and they're on a calcium channel blocker overdose. So their calcium channels are blocked, so their muscle contraction is impaired. Maybe they're having a heart attack and the wall of the tissue is damaged. Maybe they just took a bump of cocaine and they have increased contractility from that sympathomimetic medication that's making their heart slam really, really hard. Remember, this right here increased oxygen demand. So these two things have a lot of oxygen demand when the heart rate's going fast and slapping hard. And then last is volume. Volume is two things. Size of the container. So how big are the vessels, right? Are they super constricted? Are they super dilated? So you take a neurogenic shock patient who has snapped their, let's say, neck and lost vascular tone signaling to their periphery and lower extremities, meaning the blood vessels are not getting that electrical nerve impulse to tell them to constrict or dilate. They go bleh, and they just dilate. Now the person's container is huge. What happens to the blood pressure? Goes down. What happens to the contractility? Well, if their neck is snapped, they're not getting sympathetic influence on the heart. Heart rate's not going up. So they may be bradycardic with low blood pressure. That would be an example where everything is on the low end. Narcotic overdose, slow heart rate, low contractility, dilation. And then last is volume. Are they dehydrated, hypovolemic? So how much volume is in those containers, right? Is the glass half empty, half full, not full at all, or too full? So things with heart cells that are crazy is they have the ability to generate their own impulses and electricity, and they also have that stretchability. So that goes back to that Frank Starling rule, talks about the maximal point of stretch in this instance. So they can only stretch so much, but are they stretching to that point of maximum give? And that's one area we see regularly with patients that have heart attacks is we'll see their heart rate go up because their contractility is down, and they'll go into shock, shunting blood to the core, so decreasing the container size and moving that volume to the core. So that's a compensatory cardiac output change set that you see there. And then one other cool thing to know is neonates and young infants actually, because of their heart's compliance, don't have contractility like you and I do. So their formula is heart rate times volume. That's why they're so volume sensitive, and that's one of the reasons their heart rates are so high. If you go back to the different breakdowns of age-related vital sign changes, you'll see in pediatrics, specifically the younger populations like neonates and young infants, their heart rates are really, really high. A, their metabolism is high. They don't have the fat and glycogen stores you and I do. But B, they don't have the contractility, so they bank on heart rate and volume. That's why when you get a dehydrated kid, they get very lethargic very quick because they're so volume dependent on maintaining their good cardiac output. Remember the carotid bodies up here, so this would be where the neck is and the brain. The carotid bodies and the aortic arch have baroreceptors for pressure as well as chemoreceptors like litmus for CO2 and oxygen. So when you're thinking about, hey, what's some of the reasons that my heart rate would upregulate or downregulate itself? Well, you have baroreceptors here that the medulla corresponds with in the brain, and it can also help with sympathetic influence, saying, hey, we got to bump the pressure up, we got to drop the pressure down. And so the body can actually regulate pressure based on heart rate, vascular constriction, contractility, so sympathetic influence or parasympathetic influence on the slowing side, depending on what the pressure signaling is for the pressure into the brain and the pressure out to the body. So it has these checks and balances in place. And what are some of the things it goes for, right? Well, it goes for fast acting norepinephrine when it says, hey, we got to bump the pressure up. Norepinephrine is a phenomenal alpha agonist. It really constricts the peripheral vasculature very well. This is the one that's notorious for the when you feel that flushing feeling after you get cut off or you get scared because you think you're going to fall or something bad's going to happen, shunts the blood to the core and you get that rush of the blood to the core. It's that the saber-toothed tiger's chasing you down. Epinephrine on top of, so on top of the nephron, up here on top of the kidneys and the adrenal glands, is what epinephrine kicks. And it's the sympathetic neurotransmitter as well. So it helps upregulate our heart rate, the contractility, and it also helps with some of the alpha agonist. And it's also a beta 2 agonist. So it helps with your bronchial smooth muscle relaxation. So it eases your work of breathing, helps you prime to, be able to run from whatever was trying to attack you. So again, cardiac output, heart rate times stroke volume. What are these are influencing this and why is something you should be asking yourself. So that's a good review of the cardiac system. And as always, if you have any questions, hit us up at info@lifelineemstraining.com. We hope you have a great day.